Hi, I'm Dr. Gulani. I appreciate your interest in seeking help for your keratoconus. Keratoconus is a condition that has affected your vision and progressively worsens over time and impacts your vision not only in quantity but quality. Yes, it's a difficult condition to treat, but I refuse to accept that there is nothing can be done. Many patients are only given options of cross-linking and then hard and expensive contact lenses and then wait for a corneal transplant. That should not be the way it should be. In fact, my whole concept of teaching surgeons for over 3 decades, I call that think outside the cone, right? Think holistically for the patient. Keratoconus is actually a condition where your cornea starts bulging outside, becomes very thin, you have very high astigmatism, you can't wear normal contact lenses or glasses, but you can be helped. With over 20 different techniques that I do under my concept of think outside the cone, I start with patients which I call very simple into the visual category, meaning patients who can still see well with glasses and contacts, and those that I call structural, which have crossed the level of visual and now need rehabilitation before I can do a visual surgery. So the visual cases are those who are first of all stable, so they're over 20 years of age, they are provenly stable, they have a strong normal topography, obviously keratoconic normal stable topography, and on those patients I can even do LaZrPlastique surgery, which remember not LASIK, no cutting technique, LaZrPlastique surgery that I've honed for these kind of irregular corneas, where without cutting, without blades, without flaps, without any needle injection or pain, I shape your cone down into a dome and fix your astigmatism, near or farsightedness for that particular category. Takes minutes, you are done. In addition to LaZrPlastique, there are techniques further for vision like ICL and the recently FDA approved EVO ICL technology for patients who are extremely nearsighted with stable keratoconus, and even those who have astigmatism with the new FDA approval of the EVO toric ICL. It takes few minutes, you put this permanent contact lens inside the eye and keratoconus patients can see. Now, if the patients have crossed over from the visual to structural situation, meaning now they have scars, the cornea has become very thin, very irregular, can't see with glasses, contacts, I like to build them up with a strategy. So I may use intact rings. Again, with my international privileges, I have access to all kinds of intracorneal implants, whether it's Kera ring, Ferrara ring, or Intacs, which is in the US. But I can use these rings like braces and bring your keratoconus from 11 feet tall to at least 6 feet tall, so you can then wear contacts or glasses and start seeing. Now, if you've gone even worse than that intact position or state where your cornea is down to 200 or less microns, very, very weak, has no visual point and is structurally very poor, I do a lamellar graft where I shave off just the top layer of your keratoconic cornea. I put a donor cornea. Again, I don't enter your eye. This is not a full transplant, all right? Very important, not a full transplant. I put this layer to heal you. So I've now added 4 more layers of turkey slices to your 2 slices and made you 6-layered, thick and strong. I call this marination. After 6 months, I'll come back and do a visual surgery, whether that's LaZrPlastique, EVO ICL, or residual contacts or glasses for you. Correct? My aim always is vision without glasses, though you cannot guarantee this in keratoconic patients. I always tell surgeons I teach, at least guarantee yourself that you'll fight for that endpoint for these patients. So structural can go further. From there, you can also do intraocular surgery. For example, if you're in the visual stage but you're a cataract age and a stable keratoconus, I can do cataract surgery with premium lens implant that also correct astigmatism and your near farsightedness and reading, and you're done forever. Again, few minutes surgery, no injections, no needles, no pain, and you're done without stitches. Similarly, I can do piggyback lenses. If you've had cataract surgery somewhere else in keratoconus and failed, I can put a lens on your lens in the eye, again, few minutes surgery. Then I call these combination techniques. I can do LaZrPlastique combined with lensoplastic surgery. I can do LaZrPlastique or ICL surgery combined with cross-linking surgery to a procedure to stabilize you. I don't like doctors cross-linking keratoconus before correcting the cornea. I call that my keratoscoliosis concept, and see how this makes sense. You have a bent back, right? We call that kyphosis. That's what your keratoconus is, a bent cornea. If someone puts cement on that bent cornea and says this won't bend anymore, well, that's all good, but why didn't you first straighten the back before putting the cement? Therefore, I believe correct the keratoconus first, then use cross-linking if needed to permanize the procedure. You get it? So cross-linking can be used in combination with practically any surgery of keratoconus to permanize the work done. So visual surgeries like LaZrPlastique ICL, EVO ICL, cataract surgery, lens-based surgery, structural surgery like intacts, lamellar graft cornea, combinations of those techniques, and of course you can do combination or staging of all these surgeries. For example, I may plan to first structurally correct you with the intacts, then come and do LaZrPlastique to get you to vision without glasses, and then even crosslink you if needed to permanize if needed. Why spend on surgery you don't need? So I observe you. If you need it, if you're less than 40 years of age, yes, I may do that. If not, we are done. So these are the ways you approach keratoconus. First and foremost, don't let anyone tell you that nothing can be done. No matter how severe you are, it's worth the fight to get you free. And once you're free of this condition, you always have your keratoconus cornea, remember. And my whole aim is to let you never possibly go to a full thickness transplant. That is not a correct care for you. It does not mean that it's a wrong thing. It's standard of care, okay? The reason I don't like it is a full thickness, I'm a transplant surgeon. A full thickness transplant doesn't give you unaided vision. You still have to wear your contact lenses, etc., because it was stitched in 16 places by hand. That itself causes astigmatism. So now you have a donor cornea that can reject, you have medications you're on, you always have the fear of a stitch breaking, and your cornea is always weak. What did you gain then? So hence my concept is make these patients see. It's not just about surgery. So again, just cross-linking or giving you patients up to contact lenses, very expensive and for lifetime, and then waiting for a transplant does not make sense. There are so many things in between that can be done, visual and structural, even combinations to make you see. So if you have keratoconus, do not despair. Even if you've had previous failed surgeries, like we fix a lot of complications of keratoconus from surgeons all over the world, patients who've had cross-linking, they've had intacts, or they've had a bad cataract surgery, or they've had bad laser vision surgery, even transplants. All of these can be fixed because I again approach them as visual and structural, and we put these patients back into their lives with the best effort we can. So if you have keratoconus, do not despair. Me and my amazing staff right here in Jacksonville, Florida, look forward to welcoming you. For your eyes, Dr. Gulani.